CME on biomarkers, the latest tools in diagnostics. Before starting, I would like to invite Dr. Mayuri Kaikar to start Kaho session.
So before starting the actual lectures and before knowing everything, we will be conducting the quiz as we conducted in the TOES workshop. So we can treat it as a pre-test, and I'll just give you the instructions what all to be done for Kahoot. Everybody has to log into kahoot.it, kahoot.it, and then I'll give you the game pin. And then we'll be playing the quiz. And everyone is welcome to participate in the quiz. And there's this option that you can put a fake name. For some people who are really apprehensive, you can put a fake name and you can play the quiz. So nobody knows who is actually the person playing the quiz. Kahoot.it, kahoot.it. 975300. So ready to rock for the show?
Everybody can see your name on the screen.
Are you able to see your name on the screen?
Yes. Yeah. So only 15 people you can see.
Pin is 975300. Epithelial ovarian tumor, endometriosis, acute peritonitis, or all of the above. I've got a winner over here, Dr. Patil. Can Dr. Patil raise his hand? He has won this. Yes. Congratulations. I'll go to the second question. So RMI of postmenopausal woman with CA125-15, ultrasound 6 cm with no ascites. So what is the risk for malignancy in such patient? 90, 135, 95 or 130? You have 10 more seconds for the answer. Sweetie, who is Sweetie? Very good, Sweetie. Now coming to the next question, what is the sensitivity of CA125 and HE4 for prediction of ovarian cancer? 80%, 60%, 70% or 90%? 10 answers, 12, 13, 14, 15. Come on, you can click the answer. There are no negative markings. Okay. So the correct answer is 90. We've got 7 who have got the correct answer. And the fastest finger was Sandy. Who's Sandy? Congratulations. Now coming to the next question. What is the normal range of HE4 in postmenopausal women? Okay, so a little bit tough question, I guess. The correct answer is less. Then the next question. All of the following tumor markers are used in detecting malignancy in ovarian tumors except AFP, LDH, CEA or HE4. Three, two, one. So CE, the correct answer is CEA, and 4 people have got the correct answer. On the top of the list is still Sandy, followed by Vag. Who is Vag? And then Mahabharata. Coming to the next question. So the right answer is BRCA1, and 10 people have got the correct answer. And Sandy is not leaving his position from the top. Coming to the next question. Theta lutein cysts are associated with increased level of AFP, beta HCG, CEA or LDH. So the right answer is, almost everybody's got the right answer. It is beta HCG. And still Sandy is the topper. Then Samoma bodies are seen in the histological findings of serous cystarinoma, mucinous cystarinoma, embryonic cell carcinoma, or dermoid tumor. You must remember something which was there in pathology
Long ago.
not so long ago. So you feel young, right? Okay, so the correct answer is serous cystarinoma, and 5 people have got the correct answer. Sandy is again on fire. Next is tumor marker in mature teratoma. AFP, HCG, CEA, or inhibin. So we're just trying to incorporate all the things which we'll be learning today. This is just like a pre-test. So the right answer is AFP, and 10 people have got the correct answer. And JP has exceeded Sandy. Who is JP? Yes, congratulations. There's tough competition now. Tumor marker used in Brenner tumor. So CEA, AFP, LDH, or none of the above. So got 12 answers already. 14. Yes, so the correct answer is none of the above. And Vag madam has climbed the ladder now. She's the topper now.
And Ashutosh is right behind.
And he is having the highest answer streak now. So coming to the 12th question. Which of the following tumor are likely to be elevated in this germinoma? CA, AFP, LDH, or CA125? Come on, only 2 answers, 3, 4. Okay, the right answer is LDH. And 3 people have got the correct answer. So on the scoreboard, again Sandy has climbed up the scoreboard now. Coming to the next question. Maternal serum alpha fetoprotein level are increased in all of the above except neural tube defect, IUFD, Down syndrome, or multiple gestation. So we see the age value in all these except so the right answer is Down syndrome. And on scoreboard we have JP again climbing up the ladder. Then coming to the next question. Cardiac marker used for screening in high risk for heart failure patients. TROP-T, TROP-I, both of the above or none of the above. This is a little out of syllabus question, I guess, for the guidelines.
No, why guideline?
So we've got 9 plasma life span of HCG. Is it 6 hours, 12 to 24 hours, 24 to 36 hours, or 72 hours? Come on, this should be a piece of cake. Or progesterone. 9, 10, 11 answers. Last 3 seconds. And 5 people have got the correct answer. A2 or HE4. You can just click the answer. So correct answer is HCG, and almost everybody has got the correct answer. And on the scoreboard we have still JP leading the board. Next is all are components of quadruple test except HCG, unconjugated E3, inhibin A, or PAPA, PAPPA. What is not PAPA? Because it is the double marker, it doesn't come in the quadruple marker. And almost 9 people have got the correct answer. And JP is on fire. marker of placental functioning? HCG, HPL, PAPPA, or all of the above? More seconds to answer. The scoreboard still shows JP leading the board. Now this is the last question. So Sandy and Ashutosh can just do the quickest finger and then reach the top. All biochemical markers decrease in Down syndrome except HCG, PABPA, AFP or histriol. So I request all the podium winners to come on the dais and collect their gifts. I just ask the speakers to felicitate our winners. She is Dr. Jayashri Patil.
थोड़ा इधर आ जाओ वो इधर यार
थोड़ा इधर सरक जाओ
projector come on this side. एक मिनट जरा थोड़ा साइड
हाँ इकडे
wait 1 second. एकच मिनिट हां
हाँ इकडे
so get on photograph.
ग्रुप फोटो वेट
Dr. Kirti Shatta, ma'am. Dr. Kirti Shatta, she is a Chief Scientific Officer, gold medalist from AFMC College, Pune. She has over 2 decades of rich experience in diagnostics and therapeutics and is currently CSO at Metropolis Healthcare. Prior to Metropolis, she was associated with renowned hospitals in USA. Dr. Kirti pioneered established digital pathology for Metropolis in India and Africa and was instrumental in making Metropolis the first CAB and NABL accredited laboratory for WSI in India. She introduced the concept of super specialty in pathology at Metropolis by launching Oncomed, Nephromed, Gynae Expert, Pediamed, Genome Expert, Gastromed, Micro Expert, Histo Expert and Cardio Expert. Dr. Kirti has curated the research and development, academics and innovation wing to enable Metropolis offer the first and best-in-class technology and best profile for cost-effective accurate diagnostics. With her valuable support and guidance, Metropolis has been successfully driving its prestigious CSR initiative, MedEngage, which extends scholarships, academic grants, research support for young doctors undergoing training. Dr. Kirti is also on to the WHO expert panel for medical devices for cancer. She has delivered numerous courses. He is an oncosurgeon. He has been practicing oncosurgery in Nasik since last 10 years. Over the years, he has dealt with a variety of complex cases in cancer and developed his skills to align with the advancements in patient care and in cancer and women's cancer in particular. He stood fourth at his MCH entrance and his pursuit of surgical excellence and her own nursing home. She is a Medallion of NOGS and she is also attached to 9 Pulse Hospital, Nasik. I would like to invite our experts, Dr. Kshama Kaur ma'am and Dr. Ajay Jadhav sir on the stage, please. Guide us on biomarkers in gynecological malignancy, morphology to molecular based case-based insights. Thank you.
Fancy sea-facing, cabin, and the pathologist has a road-facing cabin. So in spite of this, it's common. It's okay, no problem. So what happens is Sidney Farber, who's a pathologist in Harvard, is sitting in his basement and he had the leukemic ward right next to him. And he used to see these little bachus, come die, come die, come die. And then what did he do? What all of us should do, collaborate, reach out. What is the government doing? Reaching out. Somebody spoke about doctor spoke about my CSR, where we are seeing excellent responses, trying things, doing a lot of research and coming up with some good answers. So what happens, a cell has got a problem, right? And then you create another problem in the cell and you make the cell non-viable. Cell cannot live only. That is synthetic lethality. And that is what all these mutations work on. So when you create a drug against that mutation, then that is where you see some magic. Now we all know, you all deal with these cancers, right, which are not good. This morning also, before I was leaving, I had a second opinion case, which was a very, very bad case in a 42-year-old lady. So unfortunately, it is a deadly gynec malignancy, this epithelial ovarian fallopian tube peritoneal cancer. And we know that the 5-year survival is not good, especially for advanced disease. And unfortunately, most of the cases get picked up in advanced disease because the biomarkers are insufficient to diagnose in the early phase. And that is how, even after chemotherapy, you need more options, right? You need surgery, you need chemotherapy, and then you need other options. So let's spend some time looking at this timeline. So what is this timeline? This is a timeline, the clinical precision oncology timeline. Okay, so what happened was, suddenly we know that now when estrogen receptor is positive, patient can take tamoxifen. If HER2 is positive, patient can take trastuzumab, right? So all this has followed, this is the time when it has come. So if you look at this timeline, everything that you're seeing in green is a therapeutic landmark because of a molecular target. Everything that you're seeing in blue is the most relevant diagnostic technology. And the yellow is the regulatory landmarks. So we have to try and follow regulatory landmarks because that is how the drugs become available, insurance, takes care of them, and so on and so forth. Unfortunately, we do not have Foundation 1 and MSK Impact in India, but we have collaborated with them and we can send samples of Foundation 1. Last month also we've sent 2 of them. And there are a lot of labs in India now who are doing a lot of molecular testing. But you don't have to do a lot. You have to do just what is required for a particular patient, nothing more, nothing less. And that also only if it's going to get used, right? There is no point in doing any test, the result of which you are not going to use. So what are we going to use? So let's trust data. So it's only God who we must all trust blindly, and some of them don't even do that, which is fine. But data we must all trust. Whether we trust God, whether we trust government, whether we trust anybody, but data we must trust. I always tell everybody when they come up with a query, I say, have you checked your own data? So when people say, in my opinion, I have seen this, those times have gone. There is no my opinion, your opinion, XYZ opinion. I'm sorry, it doesn't work like that. Now it's all about data. So if you have a doubt about something or you have a point to make, go back and see your last 100 cases. Did you actually see that happening? If it did, then yes, that is how the trends are going. So data has become very important. Now when you look at this data of cancer, this is the Globocon data, the latest Globocon data. We know what's common in our country, right? But then we also have these gynec malignancies that we're talking about. Among them, we know cervix is the biggest problem, then of course the uterus, and followed by the ovary. Fallopian tube, vagina, vulva, very, very negligible. Of course, these cases come few and far in between, but the top 3 definitely take the cake. Now, you use every tool possible. You use blood, urine, FNAC, cytology, pap smear, tissue, paraffin block, whatever it is. You use your eyes, IHC, fish, cytogenetics. One has to use everything. Now, we'll just spend some time on what are these gynec biomarkers that we all know of and the algorithms. And the Kahoot, doctor has already sensitized everybody on these, so I'm not going to stress so much on this. Now, what is it really required for? Why do you need these biomarkers? So before the surgery gets done, you want to differentiate between benign and malignant. You have a case, right? So you use CA125, you use serum HE4, you use Roma, you use all this. But what is the guidelines around this? You use them, which is fine. You know that sometimes they help you, you know that sometimes they don't help you. You know sometimes they are specific, sometimes they are sensitive, and it depends from case to case. Now, FDA has approved the use of Roma, Ova, and Overa, right? And ACOG also suggests that you can use Roma and Ova for deciding when to refer to a gynec oncologist. But NCCN does not recommend these biomarkers for determining the status of undiagnosed adnexal pelvic mass. Please note the connotation difference. Undiagnosed. Once the patient is diagnosed, yes, very, very important. Why? Because the CA125 level is going to correlate with your clinical course of the disease, with the monitoring, with the response to therapy, and it's an excellent marker for surveillance and for recurrence. So please remember, a biomarker may or may not be present in a tumor, depends upon how differentiated the tumor is. But if a particular tumor is releasing a particular biomarker, then it becomes the biomarker. It follows the patient's carcinoma through his life, and you can monitor it very well. I have a very close friend who has a malignant tumor, metastatic, which, I mean, we've been to 10 top oncologists, and there is a dilemma whether it's a metastatic breast cancer, metastatic prostate cancer, or a malignant adenic cell tumor. But you know something which is a biomarker that he has positive? Serum PSA. His PSA has been positive from day one. And that PSA waxes and wanes with the biology of the disease. So you have to identify the biomarker of your patient, that what is positive in this lady, and don't leave that, because that tumor is secreting that. Unless there is metastasis or there is another site, because then sometimes there is a mutational switch and the tumor changes, right? You must have seen that very commonly, that first the tumor is secreting something, then it stops secreting something. Now there are other markers also, because there are other tumors also, right? So they are the less common ovarian cancers, right? So you have your inhibin, alpha-fetoprotein, beta-HCG, LDH, very useful sometimes, CA19.9, CEA, all of them can help you. All of them can help you in different situations, but you have to know which situation. Of course, sex-caused stromal tumors, they produce inhibin, again a very good marker. The other day I had a case, it was called as sarcoma. It was diagnosed as sarcoma and it was metastatic, and somehow it looked like a granulosa cell tumor. And we did serum, and we told the clinician, just try a serum inhibin, and we ran all the markers, inhibin, calrate, and I'll show you that case, and it was positive. So it was a malignant granulosa cell tumor. So you don't know what's going to surprise you, right? So use all the biomarkers in your disposal. Now let's very briefly touch upon all the 3-4 common cancers. So CS cervix, I think everybody knows the goal, 90-70-90, right? That is the WHO narrative, that is the government narrative, that is the global narrative. What does it say? Let us vaccinate all our girls, 90% of our girls. Let's first just do that, right? And if anybody asks that question, ideal time obviously is to vaccinate between 9 to 14 years of age, but it's never too late. Even till the age of 25, people are getting vaccinated, and it's fine. Because we know that most of the cancers are caused, most of the cervical cancers are caused by 16 and 18, which is included in the vaccine. So the first step, just vaccinate 90% of the girls. Second step, screen 70% of the women with a high-risk HPV, good screening test, right? I'll come to that. And the third, these screen-positive women, 90% of them should be treated. Otherwise, what is the use of finding them? So they have to get optimal treatment. So 90-70-90. Now, the rule changes a bit for HIV positive and HIV negative, right? So normally, in a normal population, you will start doing this HPV screening only after the age 30 and every 5 to 10 years. That is what the current guideline is. And while for HIV, you do it every 3 to 5 years, and you start early at the age of 25. So I'm not going to go into how common it is. All of you know how common it is, and you know very well that HPV causes 90% of CS cervix. Not only squamous cell carcinoma, even adenosquamous, neuroendocrine, you name the cervix cancer, and 90% of them are caused by HPV. So HPV definitely is a menace. So spend 1 minute on this slide. Do not screen girls before 21 years of age. Do not screen. No screening required. Okay? From 21 to 29 years of age, just do cytology. Do not do HPV. Why? Because they're all very sexually active. HPV is a common cold of the cervix. Anybody who's having sex is going to have HPV infection. You're just going to be over-diagnosing HPV, over-treating HPV. Later you will have an incompetent os and things like that. So we are not to do HPV at all till 29. We start doing HPV at 30. At the age of 30 to age 65, we have to do HPV. Now you can do it in 2 ways. Either you just do an HPV, high-risk HPV screening, don't compromise over there, do it every 5 years. Or you do a co-test, LPC, you do an HPV and you do a pap smear and sit pretty for 5 years. You can tell her, go home, 5 years, nothing to worry if it's negative. Because you've done 2 sensitive tests. You've done a liquid-based cytology, which is sensitive, and you've done a high-risk HPV, which is sensitive. Once you've done these two sensitive tests and you've got a negative report, you can, relax for 5 years. Call her back after 5 years, you'll get a good compliance. Now, if the lady, now people say that, after 65, put them off screening. Does that hold true for India? I'll give a chocolate to anybody who answers that. Yes.
Patient is CIN positive, she should be screened further even after 65.
Yes. Another thing, why we cannot put Indian women off screening after 65?
Because they have not been screened before.
Brilliant, because they've never been screened before. So this guideline is for America. This is American Society of Obstetric Gynecology, US Preventive Task Force, American. This is not an Indian guideline. So it does not hold true for India. Because that lady has never walked into your clinic only till 65. So whenever you see her, you catch her, you please do a pap smear and a HPV. Forget the guideline. Because at least once in a lifetime, Bichari, she should have a screening, right? How many people are screened, by the way, over here? Not bad, yeah. But we can make out, right? Even all of us so knowledgeable have not screened ourselves because it's a horrible test, right? So now, let's see. So that's why don't do it before 5 years. Don't do this annual pap. Please don't torture these women. They'll change the gynecologist. Okay, so, there was this, how these women, they worship their husbands. It's not only in India, it's again in all over the world. So how did Papanikolaou achieve what he did? Because of Mrs. Papanikolaou, by the way. He used to do her pap smear at all cycle phases. And that is how he studied the normal and then the abnormal. How many people want to salute Mrs. Papanikolaou, right? And then of course there's Zurhausen, who actually brought out this concept that HPV causes CS cervix. So I always believe, I always tell the juniors, understand what the seniors have done and build on it. And these are two mega seniors who left us with two excellent things. One, pap smear can reduce CS cervix incidence like anything, and HPV causes CS cervix. So hats off to these two people. And with that, what is the problem? Now you do now only 5 people raise their hand that they were pathologists. So that means rest are clinicians. Can make out which of these slides is easier to read. Finding an abnormal cell in a pap smear is like finding a needle in a haystack. So you only imagine, even the best of eyes, best of everything, conventional pap smear, it will be limited. Because with LBC, it's just like a whole new world, right? How many people have switched over to HD, OLED, CLED, God knows how many different types of TVs are there. Why? Because the clarity is better. Simple. So with LBC, what happens? First of all the material that you have scraped goes into the container. It doesn't go into the dustbin, first thing. Second thing, it all comes on the slide. And because it is, centrifuge and put on a membrane filtration, everything gets caught. It's impossible to miss anything. So we saw that we were able to diagnose 4 times more L cells and N cells than with conventional. Though we get very good, it's an international paper, I'll circulate it later, we've published it, and it's amazing. And of course, you have to give the report as per the Bethesda guidelines. Again, there is no my way, your way. We don't say atypia, dysplasia. These words don't exist. Either something is benign or it's reactive or it's malignant, okay? So now, when you do a co-test, what happens is that you get a objectivity to this subjective test. So you have a L cell, somebody has called something L cell. But HPV has not been done. So now you're sitting and thinking. Now what you do, you send the slide to 2-3 more people. Is it going to help? No, they all did same MD path. Okay, so what you do HPV instead. And this is a case where it was, you can see the coilocytes, beautiful coilocytes, and then the HPV was 16 positive, very clearly a case of L cell. But that's not what happens. Now there was a similar meeting like this once in Bombay, and I was giving a similar kind of talk. I think half the people were not listening. And then later, I got a call from a gynecologist, very top gynecologist of South Bombay. She said, Kirti, what you were saying about that HPV pap smear, now my niece is there, she's in UK, she has got some atypical report. So what do we do? So I said, ma'am, have you done HPV? She said, no. You just see and tell, no? You just see, or should I send it to this one, that one? I said, no ma'am, you please do HPV and LBC and then we will see what we can do. So sometimes it's Googling, taking multiple second opinions doesn't help. You have to just go in for a confirmatory test. So that same girl's test we did, and this is our Syntec preparation, the ServiSafe test, and you can see the P16 and the Ki67. This brown is P16 by the way, and the red is Ki67. So we reported this case that we can see the HPV viral integration into the host cell genome, and the Syntec plus is positive, and the diagnosis is L-cell progressing into H-cell with an HPV of 59. And she got a shock when she saw this report. She said, this is a histo report, molecular report. I said, no, this is a PAP report, molecular PAP. So then she did a leap, and this is a biopsy of the same patient. As you can see, it's proper high-grade dysplasia, cervical intraepithelial neoplasia. And this girl, she just got, this is a 7-year-old case, and she had just got married that time and gone to UK. She's still very much okay. She just had a leap and she's off. She gets an annual PAP done, everything good. So P16 and Ki was positive. So what I'm trying to say is that use the biomarkers, they come to your help. Now this is a case of cervical adenocarcinoma. Again over here somebody had thought, is it endometrial carcinoma or is it cervical adenocarcinoma? HPV, P16 is strongly and diffusely positive. It's HPV associated. It's a cervical adenocarcinoma. Yes, some uterine carcinomas can also show P16. For example, serous subtype. But then the morphology is very different. Serous carcinomas look very ghastly. Okay? Then this is adenosquamous carcinoma, neuroendocrine carcinoma. They will all have HPV positive. So don't underestimate the power of HPV, whether in screening or in diagnosis or in follow-up. Okay, because 90% CA cervix is associated with HPV. I cannot underline this more, right? Now, a few more important biomarkers from cervix perspective for squamous, adeno, and adenosquamous. For recurrent disease, progressive disease, metastatic disease, also PDL1 is done. PDL1 is an immunotherapy biomarker, and MMR, MSI can also be done. And there is a new kid on the block, NTRK. What is NTRK? NTRK is a fusion which is tumor agnostic. Now this new concept has started because a lot of molecular tests get done, NGS gets done. So what happens, you discover these biomarkers which are not specific to a particular tumor. They are tumor agnostic. They can be present in various tumors. But once they are present, you can give the treatment. So that is how this comes up. Now let's move to a little more space which has become very, very important. Earlier we used to do genetic testing for hereditary cancer and molecular tests only for positive family histories. But now that's not the case, right? Why? What has changed really? So there is a concept of germline BRCA and somatic BRCA. So very simply put, remember when the blood is tested. So if there is a family history of breast cancer, ovarian cancer, and you're checking whether the rest of the family also is predisposed, you don't get exposed to it. You can use it. So sometimes I see people sending in that some red color solution, eosin, this, that. No. For everything, 10% buffered formalin. Now, even when you have malignant ascites and you want to do IHC and molecular on the cytology also, it's very okay, no problem. We can make a block out of that fluid also. But that also then has to go inside formalin, it can get made. And generally we need 30,000 nucleated cells to get 50 nanograms of DNA, for which we can do everything after that. So I'm going to share with you some of our HPOC experience in head of the pancreas, and it showed a BRCA positive. So what I'm trying to say is that sometimes you will see mutations, fish markers, different biomarkers belonging to different tumors sitting in unexpected sites, but that's okay, that is all associated. So this tumor, as you can see, this does not have the usual culprits. This in fact has a CA19.9 positive. Now there are some things very, very important. Never do a genetic test without a genetic counseling. It's very, very important. Because you can get all kind of, what is it basically? It is like a Janam Kundali. What is Janam Kundali? Somebody is saying this is written, but it's not necessary that it happens, right? Or does it? So it's exactly like that. That there's a possibility of something happening, a probability of something happening. It is not definite that is going to happen. It's just an association. So for this, if you're doing it directly with your patients, it's fine. If you're not doing it, you can reach out to us. We can get a counseling done for the patient, because the patient needs to know the risk. she's not even a patient sometimes, she's just a walking, talking normal girl, right? So she needs to know the risk assessment, she needs to, get educated, you need to inform her of the various choices that are available, and so on and so forth. So counseling becomes very important. Now let's come to the biggest menace, right? Most common tumor that you all see all the time apart from uterus and cervix, the ovarian cancer. Now, traditionally, how did we know these ovarian cancers? We knew them as epithelial, sex-caused stromal, germ cell, mixed cell, and various types. Today, how do we look at ovarian cancer? Type 1, type 2. What is type 1? Low grade. What is type 2? High grade. Very, very important. So all your low-grade serous carcinoma, endometrioid carcinoma, clear cell, Brenner, seromucinous, everything will come in your low grade. And these are the ones which are more of RAS mutations and others. And these are the ones which are associated with endometriosis, or fallopian, some borderline tumors that always progress. While type 2 is your high-grade serous carcinoma, undifferentiated carcinoma, carcinosarcoma. And these have the P53 mutation and the BRCA mutation. So I won't go into the details of this, but suffice to know that there are various places where the biomarkers act, and this is exactly where the drugs act. So if we look at the type 1 pathway and the type 2 pathway, we can see very clearly that your BRCA is more commonly associated with the high-grade ones, and P53 is also associated with the high-grade ones, while the KRAS and all are associated with the low-grade ones. And now there is another marker, BRAF, which has come up, and sometimes you see it as a surprise in lung cancer or in ovarian cancer, and it's very useful because there are drugs available for BRAF mutation as well. So again, to summarize the tumor molecular analysis in ovarian cancer, first of all, once a patient has ovarian cancer, fallopian tube, primary peritoneal cancer, the patients must be referred for a genetic risk evaluation and the germline and somatic testing for BRCA. So if BRCA comes negative, also some people do the HRR or the HRD, you must have heard. So that also, if it's proficient or deficient, again the same connotation applies as a BRCA. Now what do you do upfront and what do you do in the recurrent setting? That's important. So upfront only BRCA is done. And in the recurrent setting, you also can add HRD, MMR, MSI. But by that time, the patient has gone to an oncologist and he will take the next best course of action. So I will not go into the details for this forum. Another thing is, if you do not have a tissue, even a liquid biopsy can be done. All the labs have validated all the assays on blood as well. So it's okay if no block available, block is over, block depleted, no problem. Most of the things can be done on liquid biopsy. There are some FDA regulations around some of them, but that's again not for this forum. Now typically a high-grade serous carcinoma will give you a WT1, P53, ER positive. So, and sometimes you get surprises, right? It's not an ovarian cancer, it's a Krukenberg tumor coming from the gastrointestinal tract. And sometimes you get even bigger surprises, like this was actually, it was removed as an ovarian tumor, but the entire ovarian cyst was benign. And there were these tiny, tiny nodules sitting on the serosal aspect of the tube and the ovary. And they were deposits of malignant melanoma. Right? And then when we probed, then the patient said that 8 years back she had got a small lesion in the leg, which obviously, had got missed or whatever, removed but not treated further, and now it's a metastatic melanoma. So you do get surprises like that. Then there is dysgerminoma. So you see, young lady, LDH. We were talking about LDH, right? So this LDH was 2000s, and it was a very clear dysgerminoma. Now this was a case that I was talking about, that if you can see the image below, it's a very sarcomatous appearance. So this was diagnosed as a sarcoma. But actually inhibin, calretinin, vimentin, everything came positive. And this was a malignant granulosa cell tumor, right? So the whole treatment obviously changes. Now, even in this, so this I've already covered, I'll not go into the details because it's not an oncology forum. Now in endometrium, now let's come to endometrium. So this molecular conversation has not started now. This has started since 1998. This is a seminal paper in the journal called Oncologist, where Lynch described this. He actually described a pedigree of a family showing all early onset synchronous carcinoma of the endometrium and ovary in two sisters, early onset carcinoma of the cecum in the proband, and cancer in the paternal lineage also. So these associations have been there for a very, very long time. It's only now that they've started getting tested. Now let's look at the typical clinical scenario of an endometrial carcinoma. Thankfully, in endometrial, the story is a little better than ovarian. Because why? Because they start bleeding. So they come to you, you do a curettage and you're able to diagnose it. Vis-a-vis an ovarian tumor, right? It gets diagnosed late. So fortunately, endometrial carcinomas get diagnosed quickly in early stage, low grade, and that is why they do much, much better, right? NCCN and European guidelines both agree that there has to be an expert pathologist who has to report on these cases, then only the treatment can be planned properly. When you, sometimes you get queries, did you see LVI? Was there lymphovascular invasion? So what we call as significant LVSI is when you see four of those vessels in one field. So that becomes very important. Now sometimes now I'm started seeing that apart from your ERPR, even in endometrial, HER2 is being asked for frequently, and we are seeing HER2 positive endometrial cancer. So that will also become important. Molecular testing in endometrial cancer is not yet picked up that much, and rightly so, because it's not that complicated. You have to do all the molecular tests. See, you cannot just do some in them. So generally, because it's an early disease, early tumor, low grade, generally gets managed. But I will come to that later. When we look at Lynch syndrome, it's very interesting, These tumors look different even under the microscope. So as we all know, generally we see a hyperplasia, atypia and carcinoma. But when you see a well-differentiated carcinoma without any atypia, and then you see more than 50% myometrial invasion, and that also sometimes involving the lower uterine segment and a lot of TILs, tumor-associated lymphocytes, we start thinking of Lynch. And then you will see it in our report that, this is advised. And then you can go ahead with it based on the age. So if your patient is less than 60 or more than 60, that's how it happens. So more than 60, obviously very selective, but less than 60, universal screening at least for 4 MMR proteins, And then if MLH and one more come positive, then it is better to do a methylation also to see whether it's sporadic or it is associated with that. So as I said, very less frequently asked for, but we do see these associations. This is our data across all the organ systems. And in this case, IHC is good enough. So if you're seeing a retained nuclear expression, nothing is going to come on molecular, it's all going to be good. But if you are seeing a loss of a nuclear expression, then MSI can be done and it will show you, it will confirm the findings. So again, these are few of the endometrial cancers in which this is requested for and done. POLE mutation is associated with low-grade tumors, carries a good prognosis, but it is not available commonly and hence not asked for frequently. But it's a good idea to know because patient may come and ask you कि मुझे POLE mutation करना है क्योंकि उसमें prognosis अच्छा होता है. Because patient जैसे ही Google करेगा endometrial cancer डालेगा POLE mutation दिखेगा. So that is why I'm just telling you. Another thing that's become important again is immunotherapy. So right in the beginning we spoke about chemotherapy, targeted therapy and immunotherapy. So immunotherapy, just a little word of caution over here. So for targeted therapy, the markers are very bona fide. We have ER, HER2, whatever. We know that this tumor is responsible for this response. But in immunotherapy, the best marker of immunotherapy is still work in progress. There are some surrogate markers like PDL1, tumor mutation burden, MSI, and can be done. So just suffice it to know that that can be done because there are drugs like pembrolizumab which can be given. So I will not again go into the details of this, but take you through a very common endometrial cancers. So most commonly in the endometrium, what do we see? Either we see an endometrioid carcinoma or a serous carcinoma. If we see a sarcoma, we see a leiomyosarcoma or an endometrial stromal sarcoma. And sometimes we see both, carcinosarcoma, malignant mixed Mullerian tumor. So this is a very typical, well-differentiated endometrial carcinoma, and they do fairly well. Vis-a-vis the serous type, which do not do that well, and they have a very, very different morphology and very, very different biomarkers. So this is a serous carcinoma. You can see even to a non-pathologist, it's looking very, very scary as compared to the first case, 68-year-old lady, glandular papillary carcinoma, very, very pleomorphic nuclei. And as I told you before, P16 comes positive in these serous carcinomas, and P53 is also overexpressed. So these are high-grade uterine serous adenocarcinomas. And you do see leiomyosarcomas, commonly we report them very, very often, This was a 51-year-old lady with a leiomyosarcoma, but one has to always remember of endometrial stromal sarcoma. So this was a very interesting case. It was actually diagnosed as synovial sarcoma because it had occurred in the lung. So it was diagnosed as a synovial sarcoma of the lung. And then when it, when we saw it, it looked something like an endometrial stromal sarcoma. And again, when we probed for the history, we got to know that she had been reported, she had had a hysterectomy 10 years back or some 7-8 years back, reported as a leiomyoma that time. Dished out those slides, that was a low-grade endometrial sarcoma. And now she had a high-grade endometrial sarcoma. So just be very, very beware of these high-grade endometrial stromal sarcomas because they can surprise you like anything. They can metastasize also. And they can be picked up by immunohistochemistry very well with CD10, 56, cyclin D1 and other markers. Sometimes we see both carcinoma and sarcoma sitting next to each other or well entwined in each other. Either way, they have to be treated and staged like carcinomas. Sarcomatous is the poorly differentiated part of them. So cancer is a word, not a sentence. Hope I was able to explain that through this little presentation. And another book that you can pick up is the P53, the gene that cracked the cancer code. Another very good book to read. And just last 2-3 slides, a few unusual cases, complete bouncers, they surprise you. So, neuroendocrine carcinoma one does not think of in the endometrium. Cervix, yes, but endometrium, no. Well, but you get some menopausal, pyometra, endometrial thickness 6 millimeters, and it was a full-blown neuroendocrine carcinoma of the endometrium. Only in the endometrium, not in the cervix. So it's important to catch them the way they are. Another very interesting case was, it was again reported as carcinoma of cervix, but actually it was sarcoma. And it was not your usual leiomyosarcomas or GIST or melanoma or anything. It came negative for nearly everything. So this was an NTRK tumor, and it is important to know in the cervix you can get these NTRK associated sarcomas, and it's important to diagnose them because there is a treatment available for them. So that's why it becomes important with these biomarkers. And sometimes a non-tumor is called a tumor, right? So this was a 42-year-old lady, hysterectomy done, reported as a carcinoma because of the very infiltrative pattern. If you can see, this tumor is very, very infiltrative, but actually it's not malignant tumor. It's a very interesting tumor, and if you rely on IHC, fancy case coming positive, so you will further think of carcinoma. But Vimentin was also positive, calretin and mesothelin were positive, SMA was positive, WT1 was positive. So this was actually a uterine adenomatous tumor. It was a benign tumor. So there is no magic marker of malignancy except for an experienced eye. There is no magic marker. Because if this was diagnosed on IHC, it would just call as a carcinoma. So please, trust your teams and try to do confirmatory tests, relative biomarkers where and when they are important, because unfortunately there is no effective screening method for ovarian, fallopian tube and peritoneal cancer. So these cancers do get diagnosed late and then they have to be treated with a lot of aggression to help these women. Thank you so much. Bye-bye. You would like to add to something that I said or correct something?
To the molecular
Biomarkers.
So, I think most important is to just realize that there is a lot going
Dr.
into
Zadav, can you
oncology,
come?
especially
Yeah, that's what I was
oncology.
requesting him. Please, please.
It's most important to just realize that there is a lot going into oncology and oncopathology in particular, and these things are really guiding a lot of our decision making today. And when even 8-10 years back, that was not the scenario, at least in India, and things were just warming up, things were just changing in the Western world, and the world is changing really fast. And even today in India, we are making these decisions based on the molecular markers, the biomarkers, and the pathologists are playing a great role in it. In India, cost does affect the decision-making process, but wherever possible, wherever feasible, these things really help the patient. apart from that, I think she has already explained in details a lot of things. I don't think I need to add anything. I have learned a lot myself. Thank you.
I think your question is, we do a biopsy for ovarian cancer. Uh, for something which is presenting itself,
If I am looking at something which is presenting itself as an ovarian lesion only, then I'm not going to do a biopsy unless there are some pressing reasons in very rare circumstances. But I would avoid a biopsy in the early cases where you don't see any ascites or mental deposits or anything out of the ovary. So a lesion confined to the ovary, I wouldn't do a biopsy. For a lesion which has already spread out of the ovary into the peritoneum ascites, I think those are the areas where I would prefer to have a confirmatory diagnosis before I go in. And that is also yes and no. If I am doing a diagnostic laparoscopy, if my imaging is really highly suspicious, everything else, my biomarkers are high, in that case I might do a laparoscopy diagnostic lab to start off, and I might do a frozen section. But if I have ascites in that patient, I would do a cytology and try to get a confirmation before it.
Because momental biopsies, I suppose we get, many times happen that, especially in solid tumors, we just get very morphologically typed.
Actually, I look at biopsy. What is true cut biopsy? It's actually the formal word is CNB, core needle biopsy. So what do? You earlier used to do an FNAC, right? Now FNAC, please throw it in the dustbin if you can. It's the most useless test on earth. It should be banned. It's obsolete because you can't do much with that test. You are giving a presumptive diagnosis, not a final diagnosis. Second, you cannot do anything on it. You cannot do IHC, you cannot do molecular, right? Because you're just a cell is on the slide. So the core needle biopsy has now become the standard of care. The choice of the way a sample is taken, as Dr. Ajay very correctly said, that when you have a limited disease or a bona fide case, you don't need to. But when you need to know what the morphology is and we need to do the tissue diagnosis to decide the treatment, there is no other option but to do a core needle biopsy. So core needle biopsy, let me tell you today, resection specimens that come, which come after the surgery, are only for staging. They are not for diagnosis. Diagnosis is already made before on the core needle biopsy or the true cut biopsy. So I want to just stamp this point over here that it's okay. True cut biopsy is okay. And the pathologists over the last 10 years, 15 years have become so good at a true cut biopsy. You put a 0.1 centimeter tissue also in front of me, I'll be able to tell you in a second what it is. Because we have tuned our eyes to it. We have tuned our eyes to seeing only this much. Tumor may be 2 centimeter, we can only see 1 centimeter. And that also only 0.1 millimeter thickness, but that's fine. Because the surgeons have no option, oncologist has no option. They have to take a core needle biopsy. My only suggestion is treat that core needle biopsy like a nai naveli dulhan. Don't butcher it, don't do anything to it if you know you cannot close the process, because that same tissue, I don't know how many times I must say tissue is the issue, right? So that tissue has to go for histo, IHC, molecular, so much has to happen with that tissue. So that time of taking multiple cuts, deep cut, repeat cut, thin cut is all gone. You take one cut, you give a histo diagnosis, you cut a few more ribbons same time, you do IHC, whatever you need to do, and leave the rest of the block for molecular. And even on the tiniest tissue, everything is possible, whether it's a lymphoma or whether it's a carcinoma. So it's completely all right. We have to diagnose things on core needle biopsy and we are very, very comfortable. Not a problem.
Just to add a practical point to it, many a times you have tumors, not particularly ovarian but any other case, you have tumors wherein they are covered with a mucosa or lesions or some suspicious or shabby looking mucosa when the tumor is actually lying underlying, or you might have a full tumor where you have necrotic areas and solid areas. So if it's a guided biopsy, well and good, but many times I am not, the things are not available. With a core needle biopsy, I can actually go on multiple directions and actually that might give you a better diagnosis. So given a chance, I would still prefer a core biopsy over any other form of biopsy. And I think since last 10-15 years, unless required, I have always, that's the default case.
when ma'am told me to be part of this, like I felt like going under the sea and seeing a new world. We have so many options, and very simple take-home message which I felt I should underline is when we take family history, when a patient comes to us, we should be taking family history in terms of usually we take family history for breast carcinoma, but along with that we should take intestinal carcinoma also and ovarian carcinoma, so that we can focus on subjecting these patients for these tumor markers, and we can catch more of such patients. Rest, we have seen all the new world, and we have lot many to study. That's all. Thank you.
Thank you so much for stressing.
Sonography picture is telling us the fibroid, the doctor is saying it is a fibroid, and first to differentiate
So-
between a leiomyoma and a sarcoma.
So ma'am, what I have seen in my correlation, when I've taken out all these cases, generally leiomyomas are multiple, while leiomyosarcoma is a single mass, first of all. Secondly, it's not only large, but it is heterogeneous on radiology. So if you talk to your radiologist and ask him, that does it look different from the other leiomyomas? Because there is no blood marker to diagnose a leiomyosarcoma. No. You'll only know it on histology, and sometimes not even then. Because I don't know why there is a reluctance to diagnose leiomyosarcoma, which is not a good thing. I would encourage pathologists to diagnose, because if you miss a leiomyosarcoma, you're actually inviting metastasis. Okay, so that's all. Thank you so much.
Dr. Mansi Vidyaman.
Starting from local, regional, national to global reference laboratories. She started her career as a pathologist and blood bank officer in a district hospital in Maharashtra and headed the hospital infection management committee for 6 years. She has been involved in lab services, management and quality control. She is empaneled technical and lead assessor with NABL with extensive expertise in quality control, quality assurance, QMS, and is trained in hematology, flow cytometry, molecular biology. She is external assessor for 5. She was also involved in assessment of nodal TB centers across India. First and he is practicing gynecology in Nasik Road since last 10 years. Visiting consultant at a Devali Cantonment Hospital, and areas of special interest are high risk obstetrics and NDVH. We also have Dr. Akshay Sada sir as an expert. He is MD Radiology, Clinical Associate at Lilavati Hospital and Research Center, Bandra, Mumbai, and consultant at Thane Ultrasound Center, Thane. Special interest in fetal medicine, musculoskeletal ultrasound, color Doppler, ultrasound guided interventions, and elastogram. May I request Dr. Akshay Sarda sir and Dr. Nitin Patil sir to please join us on stage for our second session.
And thank you for giving this opportunity, and today I'll be here after this very vast session. I feel like I'm going to lighten you, and this topic is quite close to my heart. I would like to have discussion on this topic, and would like to have this session as more interactive than uh, everywhere. Means, whenever we discuss on aneuploidies, there are many things which you people would like to discuss, and even I would like to learn many things from you over here. So first of all, what is aneuploidy? So aneuploidy is defined as having one or more extra or missing chromosomes, which leads to unbalanced chromosomes, chromosome number in a cell, and which leads to various trisomies or uh, various aneuploidies. So because each chromosome consists of 100 number of genes, so the loss and the gain of large chromosomes segment disrupts significant amount of genetic material, and other results in non-viable pregnancy or offsprings that may survive after birth. So in case of surviving newborn or congenital birth defects, failure to thrive newborn or functional abnormalities which include mild to moderate intellectual disability like autism, infertility and shortened lifespan may occur because of these aneuploidies. So commonest causes for these aneuploidies are woman age. As we all know, it's an elderly primary or elderly mother, or with the history of previous aneuploidy fetus or any presence of fetal abnormalities in previous pregnancies, which may lead to aneuploidy in future pregnancies. So ACOG, as we all know, ACOG have defined their guidelines recently in September 2020, and they say that it should be discussed. They recommend aneuploidy screening should be discussed with each and every woman during her pregnancy, ideally at the first prenatal visit. So you should not see the age of the patient, or you should not see the what was the previous history. Instead of everything, you can discuss about the prenatal testing with the each and every pregnancy. So regardless of patient's risk, baseline risk, all patients should be offered for the NT and the serum screening, that is a maternal screening. We give there are different maternal screens which are dual screen or the combined screen, quadruple screen, and also the cell-free DNA, which is known as a NIPT, that is non-invasive prenatal testing. Also, if there is any high-risk patient you have identified on the ultrasound, then also you can go for the aneuploidy screening or the prenatal screening in pregnancy. So ACOG and as well as the FMF, they have made the recommendations that chromosomal microarray analysis and newer genetic technology should be used in prenatal diagnosis. So this is the table which has been released by the ACOG. These are guidelines in September 2020 which they have released, and they say that there are different advantages and disadvantages for common screening testing, including these trisomy 13, 18, 21 as well as sex chromosomal analysis. So there are different screening strategies are available, and we can go for either NIPT or the first trimester screening, quadruple screening, or the second trimester screening. There are integrated screening which is available with combined first and the second trimester screening, as well as the NIPT and the soft markers on the ultrasound like the NT and the CRL. So all we know, screening tests are two types of tests. These are non-invasive and invasive. It's quite basic one. I don't want to spend much time on this baseline testing, but these are the tests which are available currently and we are doing it there. And there is past, present and the future available for prenatal diagnosis as well, or prenatal screening. So in the past what we were doing it commonly is a biochemical screening with the dual markers, that is beta HCG and Papa A. So slowly combined this soft markers been added in this dual screening, and it is known as a dual combined screen, where presently all of us we are doing with these two dual combined screening with the along with this beta HCG, free beta HCG and the Papa A, we are adding NT and the CRL also, as well as we can go for the preeclampsia screening by adding PLGF in the first trimester screening. There is presently we are doing Quadruple screening, in past we were doing triple marker, triple screening, but which is now outdated one, and today we are going with the quadruple screening. Earlier we were doing only means after, if anything is there or if there is any previous history of any aneuploidy, we were going for the amniocentesis or the amniocentesis by karyotyping. But now it's non-invasive test is available for the aneuploidy screening or the prenatal screening, that is NIPT, and along with karyotyping, FISH has been introduced, because as we all know, karyotyping needs cell culture, whereas FISH is doesn't require any cell culture, and we can go in the targeted approach. In karyotyping, we can just see the structural abnormalities if anything is there, but with the FISH, targeted screening is available. But future is very different. Future, we are going with the quadruple screening, we are going with the dual marker combined screening, as well as we are going with NIPT and the microarray. I mean, many of the people say that is NIPT going to replace maternal screen? So I will say no. It's not going to replace your maternal screening. It has to be as a combined one only. So we all know about the first trimester screening, what we do, we have already covered, and basically we do first trimester screening for trisomy 21, 13, 18, and second trimester screening we do apart from these three trisomies, we do it for the neural tube defects as well, where we add AFP and the E3 or the unconjugated histiol in the quadruple screening or the second trimester screening. So what happens whenever we are collecting the samples, usually risk is been identified or screened on the basis of MOBs, that is multiples of medians, and where we see not only the biomarkers or not only these biochemical markers, we look for the patient's age, patient's number of fetuses are there, or we look for the diabetes, we look for the hypertension, we look for the smoking history. Many times what happens, we get only the sample, but we don't get these clinical details to identify the moms, because moms are going to change with this, and our risk is going to identify, specifically identified on combined with all these factors, not only biochemical but also the radiological markers and as well as the patient's history. Is there any IVF history available or not? This sometimes we don't get it, but if you tell us if it's IVF, if there is any donor egg is being used, we need all those details to identify exact risk, to identify exact risk of the fetus. So this is very important, what you are providing while sending the sample, and which will be helpful not only to the clinician, even to the patient. Because patients are, if there is any aneuploidy identified, it's a trauma for patient. More than us, it's a patient is suffering. So to identify exact diagnosis or exact screening, all these factors, all this history is very important. So along with that, maternal screening, the test which is available, one of the non-invasive tests is NIPT, that is non-invasive prenatal testing. In this what happens, we take mother blood, and from mother blood we take a fetal fraction from the mother DNA or maternal DNA, we take a fetal fraction, and on the fetal fraction when the amplification happens through the NGS, and we identify any trisomies are there. So along with trisomies, we look for the sex chromosomal anomalies also. But we don't, as per PNDT Act, we don't define which type of sex chromosome anomaly is available, or aneuploidy is there. We just say, is there a high risk for the sex chromosomes noted. But we have to look for the other details to go for the this testing. So there are NIPT available for these 5 parameters as well as for the advanced other chromosomes as well, other 22 chromosomes. So what is the clinical utility for this NIPT is that used to look for the chromosomal disorders, like as I said, for this 13, 18, 21, along with that 6 chromosomes, and as well as with the additional chromosome disorders. So major prominent goal for this NIPT is reduce the exposure of fetus to the risk. Second, reduce the false positive, because as we know, maternal screen is basically not only on the this thing about fetal fraction, but maternal screen majorly on the mother's hormone, how it is playing, how what is there in that maternal blood. But in fetal fraction, as in NIPT, we take a fetal fraction and false positivity will be reduced. Then enable the high detection rate. So as we know, all know dual marker, quadruple marker is having almost the detection rate of 70 to 83%. But whereas in NIPT, our detection rate goes up to 99%. Then testing that can easily be offered to pregnant women. Earlier it was not easily available, but as we all know, now majority of labs are doing NIPT. So these are the CCF, that is, those are means NIPT being done on the circulating cell-free DNA which is available in the mother. Usually we require fetal fraction of 3.5%, but 2 to 4% fetal fraction is there. We can still report the NIPT. Along with that, there are some disadvantages for NIPT. If there is any twin pregnancy or if there is any vanishing twin is there, then we cannot go for the NIPT. Still, there are chances. If you are going to send the NIPT for twin, we can give only one risk. We cannot give you two different risks through the NIPT. Along with that, we cannot go for the female who is on the treatment, this chemotherapy or any other. We cannot go for the NIPT. If there is vanishing twin, at least we should collect sample after 5 to 6 weeks. Then only we can exactly identify what is their reason. But if recent vanishing twin history, we cannot go for the NIPT. So there are some disadvantages with NIPT. And to cover it up, there is invasive testing. That is, those are cytogenetic testing. And cytogenetic testing, basically we look for the chromosomal disorders over here. As we know, subversions occurred in the first trimester. And to rule out, cytogenetic testing is very important or required for the prenatal screening. Suppose now couple is having recurrent spontaneous abortions, or if there is any infertility, or if there is any previous child is having malformations, then parental karyotyping is always recommended than NIPT or only amniotic fluid karyotyping. So it's always better to have a parental karyotyping in that case. So this is our NIPT data actually, which I forgot. It's a slides up and down. So in our Metropolis lab, we have done almost 5,000 women. We have received sample for NIPT, and our positivity rate is around 4%, where we have observed that 90% of high risk on dual and quadruple did not need invasive testing with this NIPT, because those came for those this thing NIPT, and here we get the report false positive or it's a true positive report. So 1500 NIPT cases we have seen, and in that 1500, 4% were T21, which is a very commonest one in India, as well as we confirmed one high risk case with the sex chromosome, which result was discordant. As I told, because of PNDT, we cannot declare which type of sex chromosomal high risk was there. So this question was earlier there, that is NIPT going to, or will NIPT replace maternal marker screening? So the answer will be no, because both the things are very different. One, we are looking for the mother hormone, and other we are looking specifically for the fetal DNA. So cytogenetic testing, usually we do it with we take the sample and there is a cell preparation. We usually do with the metaphase. If we are going for the karyotyping, we look for the metaphase bands. We look for the chromosome in metaphase area, and where we look for the structural abnormality if there is any noted structural anomaly in the karyotyping. So there are male karyotype, female karyotype. As we know, we can identify it on the X chromosome and the Y chromosome. There are some examples for the karyotype where Down syndrome we have identified with the trisomy 21, and when baby born there are chances of mental retardation, MC, and the dysmorphic features. We can identify trisomy 18 also, that is Edward syndrome, with the clinical correlation, and Klinefelter syndrome also. Other thing what we can identify with the karyotyping is a balanced translocation, which we cannot see it on the microarray. If at all now, as previous slide we said that future is microarray, but we cannot see this balanced translocation on microarray. In that case, karyotyping is always preferred one and recommended one. So this is the again past, present, and future. Past it was karyotyping, presently we go with karyotyping fish, and future is microarray. The advantage of microarray is that it identifies microdeletion and microduplications and high resolution, as Dr. Kirti previously said, why we are going with HD. So this microarray is HD here, and we don't require culture for fish as well as for microarray. That is faster than routine karyotyping because cell culturing is not going to require over here. So there are some cases which I am going to present what we have seen in our lab in our routine practice, and I would like to have interaction here during the case presentation only. So this is one case which is 22 years female. Pregnancy came, sample came for dual marker, and this pregnancy is with 12 weeks 4 days. Her CRL was 62.1 mm and NT was 4.1 mm. So what you have identified here? So why they have asked for the dual marker screening? Yes, because NT was high over here. So they have advised for the combined screen, and then if we see, this is our report format, or this is what our software gives. Where we take the complete entire patient details. We ask for the diabetes history, we ask for the smoking history, we ask for patient age. We take the gestational age from the either on the CRL or what mentioned in the ultrasound. So as per CRL, gestational age was 12 weeks. Here, 12 weeks 4 days was the gestational age. NT was 4.1, where mom for the NT was 2.56. Ideal mom for any parameter is 1, and whenever there is higher NT or higher mom, it gives a signal that there is something we need to look for. And if we see the risk is been identified for trisomy 21 is 1:5. So here patient have diagnosed with the high risk identified for trisomy 21, and we advise them for other testing, that is confirmatory testing. So it's usually what happens, you can advise, Ms. Gynec or obstetricians is the one who can go for the decision. Either they want to go for the NIPT or they want to go for the amniotic invasive testing. So it's your choice what you want to go. This is one case, whereas other case where same dual marker we have received 37-year female. 37-year female, and her CRL was 72.9, NT was 1.27. But if you see, the biochemical markers were working here very low. So low mom identified for HCG and Papaya, which gives here the risk of trisomy 13 and 18. Here the risk identified for, because CRL and NT was very normal. NT was absolutely normal, and so there was, because NT is specific marker for the Downs. T21, but for T13, 18 there is no soft marker available in the for the ultrasound. So we look for the mom for the biochemical markers, and if we see mom is very low, we also have truncated mom has been identified for Papaya is 0.2, and here the mom is less than 0.2. Which
T13, we have some soft markers, right?
For 13, 18, also we can get increased nipple translations, and also there are multiple cystic abnormalities we get.
Okay.
It's not necessary that we will get that always. Most of the times we do get.
That only. So only I said NT specifically for T21,
no,
but for 13, 18 it's yes or no.
NT can be raised in other abnormalities also.
Okay.
In trisomy 21 it's most commonly, But even in Turner's it is increased, even in 13, 18 it may be increased.
Okay.
So raised NT is a marker for chromosomal ability, more commonly in everyone, but others can
Okay.
also.
So what happened, being a pathologist or being a diagnostic, we just see ki, okay, NT is normal and we don't look for the T21. But suddenly with these hormones, with these markers, we identify that mom is very low and it's going towards the 13. Somewhere, as you said, means NT, your NT is absolutely normal. So it might be because how the NT been calculated.
That is also very important.
So I have one case over here where I'm going to present it. Ki if NT been not calculated properly, what can happen? So there are some few cases where I can show you that also. So we do dual marker with the SSDW platform, which is a FMF approved platform, and we look as per the FMF being have given the guidelines. So for quadruple marker, we look for the we use Prisca software, and Prisca, as you all know, again the soft markers or the history is common in both the softwares, but commonly being used for the quadruple marker. And if we see here, this is a 22 years female with 16 weeks 5 days pregnancy, and BPD being taken here for the quadruple marker screening as a soft marker, and we look for the all the moms. And if we see here, AFP mom is high. Even the HCG and inhibin moms are more than 1, and which gives screen positive for T21. So even the quadruple screening also gives gives this high risk identification for T21, T13, 18, but along with that NTD is there, and here AFP is playing a major role while calculating the risk. Again, your ultrasound anomaly scan is going to help us to fix to stamp that this is a true positive case. This is again another case where the 40 years elderly female, pregnancy with 18 weeks 3 days, and we have identified that her AFP mom was normal, AFP value was normal, whereas her mom for HCG and inhibin are low, which is suggestive of again 13-18. So as we know, soft marker, NT is going to play a very major role. So what is NT? It refers to a fluid-filled space measured on the dorsal aspect of the fetal neck. When enlarged NT, when we say enlarged, it is more than 3 mm. And it is 3 mm, we say it is a 99 percentile of CRL. It is always associated with the fetal aneuploidy and structural malformation. So meticulous technique of NT measuring is very important, is very essential for accurate risk assessment. So we have just done one case over here. We just did a R&D. We just found one lady with her maternal screen was positive, and when that baby got delivered, it was a Down's baby. Then we just checked where we have done a mistake. What was the problem? And we have found that NT played a very major role over here. Just presenting that case over here. So this is a 32 years female pregnancy with 12 weeks 2 days of gestational age as per CRL and NT. We have identified here her NT was normal. If you see here, it is NT is 1.7 mm and CRL was 58 mm. So as per that, her gestational age was 12 weeks 4 days, 2 to 4 days. With the biochemical markers, her moms were low, which we have not seen, and with the 1.7 mm NT, her NT mom was normal, and because of that, her risk came normal because it was a balancing. NT mom and the biochemical mom got balanced, and it totally came as a no risk for that. But when we look forward, when we have got the details, we have just did some R&D where we did the mistake, and we identified that when we are not taking ultrasound over here and we are just looking for the biochemical screen with the LMP, her gestational age being changed from 12 weeks 2 days to 13 weeks. With this free beta HCG value and the papaye, her mom were very low again, less than 1, and we have found that her T21 risk was an intermediate risk, which was actually been alarming, and we identified here NT was playing a role. So I request everyone, whenever you are taking NT measurement, it's always very important. It plays a very important role in doing this combined screen.
So what is the false negative rate of NT and biochemical screening together? Because even if our NT is right, also sometimes we can get a false negative right. It's not at 100% cases. Even if our NT is right, we might just get something which is
false negative rate or false positive rate?
false negative.
False negative, I'm not having data, ma'am. I'll just come back, get back to you.
False positive, for false negative rate for NT is size is the criteria. If you say it's more than 4 millimeters, then there is hardly any false negative for
So in this case, the NT was normal.
Yes.
And they did it and they found that everything was normal and the baby was having doubt.
Yes.
And then they are doing this without the NT, they are trying to come to some conclusion. So if not necessarily the NT was wrong, then would have, is there any gap that can be
The sensitivity of isolated NT is only say 70 to 80%. So 20% cases of Downs may be missed even if the NT can be normal.
Yeah.
In 20% cases of Downs also.
Because previously in past we were doing only biochemical screen for 12, and where we have seen identification rate was hardly 50 to 60%. When we added soft markers, CRL and NT, identification rate has changed from 50 to 60% to 70 to 80%. So NT played a very important role, and just wanted to wanted to check where we did mistake. So we just did this R&D for the future case. And so my request is measurement of NT plays a very important role, and it's you who obstetricians who are advising to go for the NT scan, advise them with the experienced sonologist.
The very important point here is whenever we read the double marker report, we put NT report with us, we put double marker report with us, we look at the NT image if it's taken properly, and in double marker report we don't just read if it's positive screen, negative, we look at the MOM of Papa, we look at the MOM of beta HCG, and then we see if there is any discrepancy. So we read the entire report, not just positive, negative, that's it. And also look at the NT image, that also matters a lot.
So as I have already said that marker screening, maternal marker screening is totally on the moms. It's not on the values. It's always been calculated with the population. So moms came from the population, not from the patient. So individual mom been calculated depending on the population.
Just one thing, all these values, they are being calculated by fixing the false positive rate at 5% as a fixed rate.
Yes.
If you increase or decrease that rate, then your sensitivity and specificity will go on increasing or decreasing according to that. You have to fix the false positive rate at a 5% for all the markers, and then you have to calculate the median value, and accordingly the risk will be. So in some cases it might be that the serum markers may fall in a normal range, because we have particularly taken that limit of 5% false positivity.
Because female markers are playing, as we all know, markers are at the peak level when she is 9 to 10 weeks. So after 10, 11 weeks again those markers are going down. So that is again going to. So many times many labs what they do, they take the sample at 9 weeks or 10 weeks, and again they do the NT and they add and they cross check the dual screen.
So very important question you always ask, when we should do NT scan, whether it's 11 weeks or 14 weeks. So ideally I think between 11 to 12 weeks.
11 to 12 weeks.
Because if we go above 12 weeks, then the sensitivity of NT decreases. If we go below, like close to 11 weeks, we don't identify other structural abnormalities. So 11 weeks, 5, 6 days or 12 weeks is the ideal time.
Ideal time. Yes. And as I know, please correct me if I'm wrong, that if CRL is less than 45, you cannot calculate NT also.
No, we don't do. Between 45 to 84, that is the limit.
That
below 45, we don't do it. Above 84, we don't do it.
So this was just one case where I have done gestational age calculation on the basis of LNP, and other thing I have just taken the ultrasound scan, say I have taken the gestational age. I have not taken CRLNT, but what they have mentioned in the ultrasound, I have just taken the gestational age from there and calculated. There was mild difference, but both of those were lying in the intermediate risk. So if this NT been calculated properly, we would have not missed this intermediate risk with NIPT or the amniotic fluid. We would have diagnosed properly. Just okay. So this was the same case. This is again one reflex NIPT where our this is 30 years female pregnancy with 14 weeks 4 days, and NIPT done as first trimester screen showed 1 in 14 risk for the 13-18, and NIPT gave here the exact risk. So positivity rate is, as we said, it's a 99% sensitive, and this proves that. But many times happen that screen is positive but NIPT is negative. So it's completely on the fetal fraction or the fetal DNA. So this is one case where 38 years female, screen positive for T21 on quadruple screening, and as this is the advanced age, advanced maternal age, they have gone for the NIPT, and we identified that there is T21 risk was there. Even on the background risk, that is maternal screen, T21 was positive. This is other case where the background risk was intermediate, 1 in 303, but NIPT showed negative. One more case here, again intermediate risk, and the NIPT risk was positive. So this is again intermediate risk is the criteria, and I'll happy to say that Metropolis gives or offers you Prega screen, where in Prega screen we give dual marker as a reflex to NIPT or amnio. Again, it's a choice of yours which one you want to go, either NIPT or amnio. So we have this platform available. Then this is a amniocentesis case, 29-year priming gravida underwent amniocentesis at 22 weeks of the gestation because of abnormal ultrasound, and we have identified a mosaicism over here, 47XX and the mosaicism. These are microarray. So as we all know, microarray is the future. So this is a 5 months female with dysmorphic feature, and karyotyping study is done. It is 46XX. We did microarray for this and identified that there is a deletion of chromosome 2 and duplication at 6q. So microarray is helpful where to identify deletions and duplications outside the detection limit of karyotype, where we cannot identify with the karyotype. This is another case of amniocentesis done microarray, and we found that this is a karyotype 47XX and M again. If we see here 25 chromosome duplication and 29 deletion of chromosome 13. This is product of conception microarray. This is 30 years female. There is a known case of RPL, recurrent pregnancy loss. We did microarray on the POC material, identified trisomy chromosome 10. Another case of POC, identified trisomy 8. Fish was negative for this lady for 13, 18, 21, X and Y. And chromosome usually not done because of this poor culture, but microarray can help us to identify other chromosomes also. This is trisomy 8. So counseling, Dr. Kirti have already told why to do. So every genetic testing needs to be counseled, where we need to inform patient that what we are, which test been advised, why it is advised, what are the implications of this test, and everything we need to take. As time is running short, I'm just running the PPT. So these are our genetic counselors. If you can do, even we can provide you genetic counseling from our side. So this is about Metropolis. Our lab is NABL and CAP accredited lab. Vast variety of tests available with us. This is state of art, and almost all 10 to 15 labs are having FMF platform for the maternal screening. We also do NGS by NIPT and the breast cancer mutation and genetic counseling. So our USP is this, which I told already. These are the offerings given by us first trimester screening, second trimester screening and the prega screen, what I told here. In this, if there is any intermediate risk been identified, still we can go for the reflex testing, either NIPT or karyotyping. Choice is yours, which one you want to go. These are the panels which are available with us. And thank you. I'm okay to take any questions.